What me and Dr. Bolokon will be highlighting this afternoon is basically stories on the Pearls PNG. So as I've stated, I believe will be more centered around stories, and I want to give 3 stories to start off with. So here is a picture of me trying to do a scan. The patient is a female of 27, was kept overnight for approximately 6 to 8 hours with acute abdomen, hemodynamically unstable, was pale, and slightly distended abdomen. From the picture, you can see I was trying to point out something, but really, I did not know what I was seeing. That was how it was for me before joining PEL's program. There was also a male of 22 which presented to me at my hospital after 2 days of traveling. And upon clinical examination, I suspected that that patient has pleural effusion. And the only thing that I had in my mind was to send the patient for X-ray, which I don't have in my hospital. So by sending the patient, it took the patient another 2 days to get the X-ray and then return to me. So basically, the turnaround time to diagnose a patient with pleural effusion back then was approximately 4 to 5 days. I'm highlighting the stories, as we'll be hearing more stories this afternoon about PNG. The third case is a female of 30, para 3, grade 4, presents to ANC for a routine maternal clinic and was noted to have static weight in the third trimester. They referred the patient to me as the only doctor on site for scan. And you know what I could do with the scan? I could only see the presentation, the skull, and the heartbeat. That's the only thing I can do. For fetal biometry, I have to refer the patient to the referral hospital. Before joining the program, this picture shows my experience. It was like swimming in an ocean, but I did not know where I'm trying to swim to. Putting end to the probe and seeing those structures on the screen did not even make sense to me. So here's how to outline stories are memory aids, instruction manuals, and moral concurrence. This is from an unknown author. But this afternoon, we'll be hearing stories and more stories. Stories about PNG, the health system, and the journey me and Dr. Bolokon took into the PELS program. Stories to show you all how PELS program has impacted the rural PNG. So let me take you just to get a background of PNG. If you are not sure where PNG is, this is a map that shows Australia, New Zealand, and the Pacific Island countries. PNG is located in what we call the Melanesian group of islands. We zoom in, you will see that Papua New Guinea is a vast entity, and has 22 provinces, 4 regions: Highlands, Momase, New Guinea Islands, and the Southern region. Where me and Dr. Bolokon work is East New Britain. It is one of the New Guinea Island provinces. And in East New Britain, it has a total population of approximately 457,169. It has 4 districts: Pomio District, where I work, Gezel District, Kokopo District is where Wunapope Hospital is, and Rabol District is where Nonga Hospital is, and Dr. Bolokon is working at Nonga. This afternoon, we'll be hearing stories in all these districts. As per the health system in PNG, it comprises of a network of 28 health agencies, 21 PHAs, and then we have the Country Referral Hospital, which is Port Moresby General Hospital. We have the PNG Institute of Medical Research, the National AIDS Council, Specialist Psychiatric Hospital, Buka Hospital, Christian Health Services, and Catholic Health Services. East New Britain PHA is under one of these 21 PHAs. And to highlight a glimpse of what a rural hospital in my setting looks like, I would like to take us to highlight few on Warangoi Rural Hospital. So this is a picture of where I work. At Warangoi Rural Hospital, it is governed by East New Britain PHA, the East New Britain Provincial Health Authority. And we serve a population of 15,819. In my catchment areas, we have 22 catchment points, and the hospital has only 1 doctor, saving a population of 15,819. So I'm the only doctor at Warangoi Rural Hospital, and I have 24 staff working under me. We offer services at Warangoi Rural Hospital, from inpatient to outpatient and clinics. And the thing to outline here is from our diagnostic services, we have only an ultrasound scan. So this has motivated me, or has given me the desire to know more about ultrasound scan, because that is the only tool that I have in my hospital. My experience might be similar to the rest of Papua New Guinea. And this map shows the distribution of doctor in PNG. I abstracted from the PNG Society for Rural and Remote Medicine, which the society I am a member of. This map was updated at August 2023, and it shows areas with no doctor, areas with 1 to 2 doctors, and areas more than 2 doctors. If you could see from the key, areas more than 2 doctors are the ones with light green. And this really shows the need for doctors in most part of PNG. The places where they have a light green which means that they have one or two doctors or more than two doctors, the need for ultrasound scan is real. And they share the similar experience as mine. So upon saying this, I would now hand it over to Dr. Bolokon to take us through the journey on how we knew about PELS program and how it impacted our diagnostic services in rural PNG.
All right, so thank you, Micah. It was a very good intro on the PNG health system and Papua New Guinea in terms of its rural challenges. We in POCUS in PNG has been around. In PNG, Society of Emergency Medicine has been a key component in practicing POCUS in our country. So PELS in 2023, we had our first course at Port Moresby General Hospital, where we the course delivered the ED and the critical care course, in which me and Micah were privileged to be part of the learners there, and we got certified in the emergency and the critical care component of the PELS course, and that was the first time where we had most of the probes donated. I had a BIQ ultrasound that time. It was donated by the organization Hands Water Hope, where Dr. Sarah Cookman was involved with the PNG emergency medicine, where we were running courses in the same year in 2023 during the medical symposium, where me and Micah as well were there at the medical symposium during the training. And coincidentally, the PELS, they ran the course in November, so we were privileged to be part of that, involved in the training as well as the distribution of the probe. So that's where Micah got the probe, and we brought it back to our provinces and our hospitals, and we started using it. And so we had to upload like 25 scans, and there has to be so all the scans has to be reviewed by coaches, and we had to go through this mentorship program for about after post-course evaluation, and all that had to happen after our training in 2023. So the butterfly IQ was a big step forward in terms of our skills and knowledge in doing ultrasound scan and point of care ultrasound. In 2024, we had the privilege of attending further training in Fiji at the University of Fiji National University at the Pacific, organized by the Pacific Society of Ultrasound in Medicine. That is an affiliate of the World Federation of Ultrasound in Medicine, where we did more training in echo, lung, fast, and obstetrics. So we had the privilege of doing that in 2024 last year. And we were involved for the first time, we were involved as trainers, instructors. So this picture shows Micah in Samoa with the PELS team running the emergency and critical care course over a 2-week period in Samoa, training the doctors there. It was a good learning experience for Micah, as it was his first time to be a trainer in the PELS program. And I went to Honiara in last year as well, in 2024. And we did 2 weeks course of over a period of 2 weeks, ED and critical care. We trained doctors in Honiara in Solomon Islands. So if, as you can see on this photo here on the left top left corner, you see Ellie, it's one of the senior emergency registrars in National Referral Hospital in Honero. We picked up a case, was lying on a young female lying on the floor with paroxysmal nocturnal dyspnea and autopnea. She had other non-specific symptoms. So we had on the third day of training, we decided to, okay, well, might as well just scan the lungs and the heart and see, just to rule out any pericardial effusion. And lo and behold, the patient had a large pericardial effusion. That was during the third day of training in the PULSE course. On the upper right-hand side, this is Initi, one of the emergency registrars doing ultrasound-guided arterosynthesis. So somewhere in the Honero trip coincided with the TOT course, where me and Micah were trained. We attended as a one-day course where we trained us. We learned a lot in terms of running a course in general, and as well as being a PELS facilitator. And part of the responsibility of a trainer is you have to deal with the logistics, and there was a lot of logistics. There's a lot involved in running a course, and as you can see on the bottom right-hand corner, this is us in Honero trying to engineer some IV access models. So in 2025, we had our second PELS PNG course run in Eastern Britain. This is where me and Micah work. We trained a total of 14 participants from various health facilities in Eastern Britain, as well as one doctor from KVN Provincial Hospital and Buka Hospital. This course was generously, the probes were donated, and the course was run by the Believe Inc., which they gave us 5 probes, and we were able to distribute it out to the 4 districts, as well as the 2 island provinces that came in to participate, which is in KVN and Buka. So they now have access to these probes, and they're regularly scanning patients and uploading them to the cloud, utilizing the cloud and system to review their scans. We've also used our training and some of the machines to do rural outreach. This particular place is in Yazal district in Madras. It's a rural area outside of the main area, where we've conducted a one-day rural medical outreach where we utilized the probe was utilized there before the course, actually. It was a hub of the Believe team, which was the organization that helped us helped us run the program, funded the program. So it was a success, because it's for the first time we were able to use a handheld ultrasound device in a rural outreach program. And we did a lot of scans. We saw all over 200 to 300 patients, scanning all sorts of diseases and patients. So the impact of POCUS in PNG, especially rural PNG, cannot be overstated. In the experience that we've seen, it really increases the accessibility of patients to these diagnostic services. If you have those machines and the clinical skills and knowledge that you have, you can give these patients this improved diagnostic service and accessibility to those remote areas. So it can be a really game-changing for patients as well as the health system that you're working in. It also gives you a critical care early intervention in terms of making a decision to act on this patient quickly before the patient deteriorates. Also helps with the clinical decision making when you are faced with a dilemma or a diagnostic, and you have a lot of differentials. The ultrasound scan can do that and make you have a more informed knowledge on what decision you're going to make. Additional benefits. Online coaching and mentoring is an ongoing thing that really helps builds the skills and knowledge of the participant, the learner, as well as the patient, helps the patient as well. Cost effectiveness, if the patient, if doctors who are able to access these devices, they can actually improve, reduce the costs of referrals. In like most of the situations, we have patients coming in for radiological X-rays, doing X-rays, medical evacuation. If you have those machines at the rural areas, you can cut down all of those referrals by doing POCUS. So I'm just going to go through some of the cases that we've identified to show these were all done within the time we were here in Eastern Britain over a few years. This first case is this is Dr. Micah. He was his hospital in rural Warangoi. There's a female of 30, is a power 5 gravid at 36 weeks gestation. He came into the hospital and for a was diagnosed clinically as a mild presentation. So he came in to confirm the diagnosis. So Micah did the scan and picked up a mild presentation, and he did the ECV was done to relieve to correct the presentation. So this patient would have been referred to a larger facility or tertiary hospital where I'm working. Usually Micah would send this patient to us and we would have done the scan there, and then we would have we've done the ECV and sent the patient back. And that would have cost like 2 to 3 days, even longer, for the patient just to do a simple procedure. And now Micah having the scan. There's only a case that highlights a good use of that scan machine. Case 2 was patient as 34 years came in with a web space abscess, with the abscess extending to the palmar aspect of the wrist. Micah didn't have any induction agents or benzodiazepine to do a bit of sedation to do an IND. Patient needed an agent IND to be done. Also due to the remoteness of the place, having to refer this patient to a tertiary hospital, it will be another days again, and then not forgetting the theater list and all that. So it will be a delayed in the diagnosis and management of this case. So having an ultrasound gives Micah a bit of confidence in doing a case that he would have referred if he hadn't had the scan machine, or he would have had a bit of reluctance in doing that procedure. But he was able to do the procedure and correct the patient's condition. The third case is a male of 25. He came into Punapope Rural Hospital. It's another rural hospital in Eastern Britain. He developed this severe difficulty in breathing while he was running out to train. He's a semi-professional rugby player. He had this SOB for the last 2 weeks and autopnea, but he never came to sought any medical treatment until he ran out to play rugby. So he had this difficulty in breathing, and the breathing got worse. So he came to the hospital. That was a few days after we did our PEARLS training in Eastern Britain, Kokopo. And one of our participants who had the scan donated to him, Patrick, saw the patient and did a clinical assessment of this patient. And while waiting for further investigation, he had the scan, so used the scan on the patient. So patient had all these vital signs. They had a muffled sound. So they did the subxiphoid view. It showed a large pericardial effusion with the right side, the right ventricle collapsibility. Patient was a bit tachypneic. He was conscious and alert, didn't have a drop in blood pressure. It was relatively hemodynamically, we were thinking. So we had to review this case with our physician, Rabal, and there was a bit of a back and forth. We had to review the case, the echo findings as well with our mentors on the cloud. And so we decided not to intervene with the pericardial synthesis. It's a very risky decision to make, considering the echo findings there. So we decided to start this patient on a TB treatment and a high dose of steroids, and continuously monitor the patient overnight. The hospital didn't have cardiac monitors, defibrillator pads, so even if we wanted to do the pericardial synthesis, would have been an issue with the monitoring of the patient. So the scan was done by one of our participants just a few days after the course that was running. So daily observation was done. We did several scans to monitor the patient. After 6 days of treatment, or TB treatment and prednisolone, this is the finding. Patient symptoms also coincidentally markedly improved with the disappearance of the pericardial effusion as well. So he was discharged home on treatment and had a regular follow-up. So these are some of the if things that we see a lot in PNG, where there's a lot of TB, especially TB causing a pericardial effusion, and when you start the patients on treatment, if it's TB, it improves remarkably. This case came in as well to my hospital, where I work, Rabaul Provincial Hospital. It's a male of 50 with a chronic progressive lesion, also coming from a very remote place in Lasul in the Gazelle district. Progressively swelling, worsening abdominal distension, fatigability, not eating, poor appetite, and also had jaundice. So he came in and did a scan. This was done by one of our the physician. He was recently trained, and he was donated a scan as well. So he had a PIQ, did a scan and uploaded on the cloud. It showed a large pleural effusion surrounding the liver. You can see a lobulated liver with irregular surfaces, and basically a sick-looking liver. So hepatitis surface antigen was positive, and this patient was diagnosed as a liver cirrhosis. So this is another common condition in PNG, where you see a lot of liver cirrhosis and a positive hepatitis B. This patient was well after a few days in the ward and was discharged for regular follow-ups at the medical clinic. And case number 5 is one of the referrals coming from the outer islands. In New Island province, there's a 27-year-old female with a case of dyspnea, autopnea, fatigue, had abdominal distension and lower limb bilateral edema a week earlier. The clinician's vision picked up a diastolic mammoth aortic region and rated in the left column border. Was suspecting a aortic valve lesion. X-ray showed a bilateral blunting of the costophrenic angles, mainly on the right side. So yeah, we're thinking of a pleural effusion on the right side with the, yeah, so diagnosis of a disseminated TB was made and was contemplating treatment. However, when we scanned the patient, he had so this scan was done by one of our participants in the recent pulse course. So it was uploaded on the cloud, and we were able to see the images uploaded. The bilateral pleural effusion, no fibrin strands on the noted in the effusion. So we decided to do further investigation. The gene expert for TB came back negative, but the sputum results showed a Klebsiella sensitive to ciprofloxacillin. So a revised diagnosis was done. Patient wasn't started on TB treatment, and anti-heart failures were commenced. Commenced on antibiotics. Patient stayed in the ward, recovered fully, and was discharged on the 25th of May, and he returned back to the island province of New Island, KVN. So this is another case where we see a lot of pleural effusion in PNG, and especially clinicians here know that most of our cases, if we don't have a gene expert or we don't have other confirmatory diagnosis, we always start patients with TB treatment because it's very common. The common things are common, so we start patients on with pleural effusion on TB treatment and see how it goes. And if it worsens, then we think of other things. But this case demonstrates that with this additional benefits of diagnostic services, we can be able to differentiate those who do not have TB and those who have TB. Putting together all your clinical findings to make a holistic management for this patient. Case 6, this is a female 28-year-old. I presented to the emergency department, very sick looking in respiratory distress. He had a brisk work of breathing, respiratory distress, tachycardic, low blood pressure, high dependent on O2. He had all the clinical features suggestive of a right heart failure. Hepatomegaly, raised JVP, distended abdomen, and bipiral pituitary edema. These are the echo findings that were done. These scans were done by one of our participants. On the left upper quadrant shows the left parasternal axis. This shows a dilated, you can see a dilated left atrium with stenotic mitral valves, difficulty opening of the valves. Parasternal structures views showing the sort of a calcified valves, as well as on the four-chamber view, you can see the mitral valve there. So patient was diagnosed with a case of severe mitral stenosis secondary to a rheumatic heart disease. So rheumatic heart disease is another very, very devastating disease in PNG that is sadly very common in PNG. And most of our cases here are diagnosed clinically. In the rural and as well as the big hospitals, we diagnose patients clinically, and all patients are referred to a bigger tertiary hospital for formal echo and cardiology reviews and all that. However, having those scans in our rural and peripheral hospitals, we can be able to pick up early these rheumatic heart diseases that plague our population. And also, as this also gives us the opportunity to do early screening for patients with rheumatic heart disease. So having this scan and the skills to do an echo on a patient is almost a game changer in terms of rural setting. The last case, case of female 18, came in presented to Punapope Rural Hospital. She's a first-time mother, 42 weeks gestation, presented with heavy pelvic bleeding and severe abdominal pains. He came in a state of shock, was quite tuned, low blood pressure, was resuscitated in the outpatient. And Patrick, one of our trainees, recently Pels trainee, he did a scan on this patient. Was suspecting a placental abruption based on the clinical history and the state in which the patient came in. Unfortunately, this was the only image that he was able to get. But this image shows, you can see the placenta here separating from the uterus. So there's a placental separation there with hypoechoic areas between the uterus and the placenta. So although the ultrasound scan may have a low sensitivity in picking up placental abruption, he was able to put this clinical correlation and was able to make a decision early for this patient. He was hemodynamically unstable, so had to take this patient into theater. So patient was resuscitated, and then caesarean section was done. Intraoperative finding shows a large amount of retroplacental clots, and patient had an uneventful recovery. Both patient and the baby survived, and they were discharged home soon after. So these are the cases. Some of the cases that we see is a common story throughout PNG. Common diseases that we have, and gives us some of the challenges we have, and with the diagnostic services that we have now, we'll be able to see a lot more of those and diagnose a lot more of those diseases. To conclude, I would like to just to summarize by saying the way forward to PNG rural in terms of focus in rural PNG. I think one of the visions we have for PELS is to train PNG doctors who are keen and enthusiastic in POCUS, to be competent in POCUS and be able to use the skills and knowledge and implement them in the rural areas where it can benefit greatly the population. Also, this increases the accessibility of patients receiving this timely ultrasound diagnostic services, and the patients are the ones that benefit from it. So having this increased accessibility sort of gives a lot of benefits to our health system, and it helps a lot in terms of a lot of things that happens to patients when they come to receive the services. Also, critical care, early intervention, and early decision making for time critical illness is very vital, and having a POCUS scan accessibility and having the skills and knowledge to do that greatly improves that clinical decision making and early intervention. Ongoing networking capacity building in the PELS program is a very important component that me and Micah have greatly benefited from, and sort of build us up in our capacity to deliver training in PNG, as well as helping our patients and in our hospital that we work in. And also the coaching and mentoring that's provided in the online cloud system is a very good way forward for in terms of future trainees coming up. It's a unique thing in terms of PELS courses compared to other courses from my experience. Just want to take this time to acknowledge our coaches, especially the PELS team, Jono, Peter Chang, Joe McCain, Louis. They've been our coaches, and in Claudia with Micah. They've been been us all through with us all the way, and we've learned a lot from them, and now we've come this far. Our employers is the Britain Provincial Health Authority. Both me and Micah work under the PHA. I would like to acknowledge them as our employers in terms of giving us the space to do what we do, and the patients that we scan. Those are some of the information that we gather from the patients. Patients are your best textbook. So when you scan patients and you learn a lot from them, the skills and knowledge that we have. And all our partners that support the PELS program and all the training that from 2023 up, ASM, Australian Society for Ultrasonic Medicine, NZX that ran the course in 2023, Philip Goblon, and also Health Water Hope that gave me the scan back in 2023, and the team, Sarah Cookman and them. Thank you very much.
Wow, thank you very much, Iggy, and thank you, Micah, for presenting and sharing your experiences using POCUS and how much it's changed the way you practice in rural PNG. So before I go to the opening the floor for all of the attendees to ask you questions, I just have a few questions to ask you, just to get a bit more information. So you mentioned, first of all, there is a patient when you were in Solomon Island, when you were able to identify the pericardial effusion. Do you know what happened to the patient afterwards? Like, how did you and the team manage to, or decide to manage the patient?
Yeah, so the patient was, it was like, just like most hospitals in the Pacific region. It was quite a full ED. We were able to pick this patient. A patient didn't have a lot of clinical features of tamponade, and also I think the echo findings didn't show any right ventricular, right atrial collapse. So we went to, we were worried about this patient, so we had to find a resource bed for this patient. I didn't think we did a pericardial synthesis for this patient on the same day, but patient was admitted by the medical team. The cardiologist, Dr. Emery, and the team, I think the next day with Louis and them, they did ultrasound guided pericardial synthesis the next day in the ward. So I think there's some, I didn't manage to get the images there, but we were able to see the procedure done the next day. So the patient was okay. He was started on treatment. I think it was TB, right? Yeah.
Amazing. Very
Yeah.
fortunate that the patient get to be there as well while you're doing the training. So you're able to help pick up the diagnosis and provide prompt treatment to her. So that's amazing.
Yeah.
The second thing is you mentioned about the rural outreach program when you were doing mass scanning. What were the common findings that you found in those populations? What were the things that you found?
Yeah, so we did the rural outreach. We were done on the Saturday. So if we had done it on the weekday, we would have gotten twice or three times the size of the number of patients coming in. We mainly saw a lot of musculoskeletal issues. We had one of our the instructors, Dr. Kiran. She's a radiologist, so we did a lot of those musculoskeletal intra-articular injections, so IV cortisol. Cortisol. So there was a lot of these patients with arthritis. We picked a few cases of obstetrics cases. There was one case of few cases of chronic obstructive pulmonary disease. But there was not a lot of very sick, critically ill patients that were picked up during the day. We did several ocular scans. There was a lot of issues with eye conditions that came in. So most of them had to be referred because of the specialty that they need to require. So we did some ocular scans to check for retinal detachment and hemorrhages and all that to roll out some of the differentials of eye blindness.
Mm.
Yeah, so those are mostly most of the yeah, the epidemiology at that time.
Mm. Wow, there's a lot of cases there. I don't think we PERS provide the training in musculoskeletal injuries, but we are having a lecture in a couple of months
Yep.
about musculoskeletal injuries that everyone can definitely participate in. You mentioned that Micah performed some sort of regional like nerve block as well. Is that right? During the web space abscess case.
Yep.
I think from what you're sharing here, it seems like there's a lot of scopes that we can help and support you in training, like upskilling you as well, to really cater for the need of the populations.
Yes, very true. The regional anesthesia using a regional block is very important in. I think Micah and Patrick have done few of those. I've done few of them as well, and it's a very effective way to deliver if patients with fractures and all that, and you can do a lot of management with that. And using ultrasound makes it very easy to do those procedures. So it's one of those things that you can do it in the butterfly IQ. You can change the settings and do that. And I think the video Micah showed it, but it's a long video, but we didn't put the whole video in it too. When he did the axillary block and did the procedure.
And then my last question for me is about the staff at the hospital. So Micah is having, I think, it's like 14 or 24 staff working under him alone. Do you have any plan to train other staff to use POCUS to help, alleviate your workload?
Yes, thank you for that question. I currently have two health extension officers and 5 midwives. So health extension officers are more like clinical practice nurses in New Zealand and Australian setting, or like paramedic. Currently, just informally having them on bedsides, and one of my HOs are able to do the scan. And out of the 5 midwives, just one have been showing interest in doing obstetric scan. So yes, as a way forward, we are planning for HOs and midwives to take up POCUS scanning as well. And it is one of the discussions that we have with our management here as well, to increase the access of scan to patients. Yeah.
Yeah, amazing. Wow. Super incredible stories, Micah and Nikki. So no more questions from me. I will open the floor now to all the attendees. We have quite a big group today. So I'm sure there'll be a lot of questions for you both. We'll stop the recording as well.